Good morning, everyone. My name is Annette Johns, and I'm the Deputy Registrar with the Newfoundland and Labrador College of Social Workers. Happy Social Work Month, everyone. This year's theme, Social Work is Everywhere, promotes awareness of the diverse areas of practice in which social workers are employed and recognizes the knowledge, skills, and expertise that social workers bring to these diverse areas in enhancing the health and social well-being of individuals, families, groups, and communities in this province, nationally and internationally. In celebration of the month, I'm happy to be the moderator for today's education webinar, HIV and Hepatitis C Basics for Social Workers. The webinar presentation will be approximately 60 to 70 minutes, followed by a question and answer period. And throughout the presentation, I do encourage you to type in your questions using the question mark icon at any time throughout the presentation, and I'll begin asking the questions at the end of the presentation. So now I'm excited to introduce our speaker for the webinar this morning, Julia Abundo. Julia is the Provincial Coordinator of HIV/HCV Services at the AIDS Committee of Newfoundland and Labrador. Located in St. John's, her practice is focused on supporting people living with HIV, hepatitis C, and other sexually transmitted and bloodborne infections from a trauma-informed, person-centered harm reduction approach, as well as providing education to professionals and community members. Julia, I'm really looking forward to your presentation this morning, and I'll now turn the virtual podium over to you.
Perfect. Thank you so much, Annette. So glad to be here and to chat with you folks about HIV and Hep C. It's something that I see very often in my practice, and really no matter what area of social work you're practicing in, you'll probably encounter these infections or folks who are affected by them. So thank you all so much for coming, and I'm really excited to get into the presentation. So we're going to start with a land acknowledgement adapted from First Light. So St. John's is home to a rich, diverse, and vibrant urban Indigenous community located on the ancestral and unceded territory of the Beothuk. The lands and waters in and around the city have traditionally served as a gathering place for the Mi'kmaq. The broader region of Newfoundland and Labrador continues to be home to diverse Indigenous peoples, including First Nations, Inuit, and Métis. We honor and pay respect to the past, present, and future caretakers of these territories. We acknowledge the harms of historical and ongoing colonization on Indigenous peoples across Turtle Island, one of which is the disproportionate rates of HIV infections in Indigenous communities. We commit ourselves to working in the spirit of reconciliation to provide culturally safe care to Indigenous peoples affected by HIV and to fight the systemic barriers that leave Indigenous peoples more vulnerable to HIV infection. So that is something that we are working on here at ACNL. Due to a lot of health inequities, Indigenous communities are more prominently affected by HIV and Hep C. And so we're working to provide some resources in Indigenous languages and to really meet folks where they are, to ensure that we're able to incorporate traditional ways of knowing, doing, healing into folks' process with HIV and Hep C. So a little bit of housekeeping, Annette kind of went through this as well. I also typically do this presentation over Zoom, so some of this isn't really relevant. But the presentation, like Annette said, 60 to 70 minutes with that time for Q&A. Like I said, there's some dedicated question periods. However, you can type your questions in the chat or the Q&A at any time. Nobody's got their camera on, nothing to worry about there. And I also do love to acknowledge that the history of HIV and AIDS, that crisis can be really hard for some people, that history. So, if you need to step out, if you need to take a second, please do. And if you need to connect afterwards to kind of chat about that, feel free to send me an email. I know it can be difficult for folks. So, we'll go a little bit into what ACNL is and what we do. So the AIDS Committee of Newfoundland and Labrador is a provincial community-based nonprofit charitable organization committed to preventing the spread of HIV, hepatitis C, or HCV. I'll say HCV, Hep C, hepatitis C, all talking about the same thing. And related sexually transmitted and bloodborne infections, or STBBIs. That's also something that's going to come up through the presentation. So we're looking at those through education and supportive harm reduction-based programs and services. So basically, whole mission is preventing the spread of HIV, Hep C, STVBIs, and supporting folks who do deal with those infections. So we've got basically 4 key programs. So there's the HIV and Hepatitis C Services Program, which is my program. So like it says, we've got light case management services. So what that means is I can help folks get to the HIV clinic or to blood work appointments for those located in St. John's. But for everyone outside of St. John's and in St. John's, I also help with referrals to treaters, so referrals to the HIV clinic, referrals to Hep C treater. I also often do supportive counseling with folks. It can be really difficult for folks to get a new diagnosis. So doing a bit of that supportive counseling, helping them out with processing a new diagnosis. And as well, I can also do some of those system navigation pieces. So it's not full intensive case management, but I can direct folks to housing supports, other healthcare supports, that kind of thing. I also do community outreach. So that would be going to other community organizations, usually once every 2 weeks, connecting with the folks there. That's again St. John's based. We are based in St. John's, but we're a provincial organization. So I am able to support folks outside of St. John's. It just looks a little bit different than what we might be doing in St. John's. And then in addition, we've got the education and advocacy pieces. So the education is what I'm doing here today, kind of talking about HIV, hepatitis C, what those infections look like, and as well doing some advocacy to ensure that services are appropriate and meeting the needs of people with these infections. Our other program that you might know is the Safe Works Access Program, or SWAP. That program provides safer drug use and sex supplies across the province. So we've got the office where folks are able to drop in, access supplies. There are satellite sites across the island and in Labrador as well. So people are able to go to different community agencies, pharmacies, that kind of thing, get those supplies. And as well, there's the mail out system and our swap van, which goes out Monday and Thursday. And again, that's within like the St. John's metro region. We've also got our 2 housing programs, so the Tommy Sexton Center shelter and our supportive housing units. The shelter is a 4-bed emergency shelter. It serves people living with or at risk of HIV and Hep C. That's kind of most folks in community. Most folks experiencing homelessness are going to be at risk for those infections, but we do prioritize those living with one of those infections. That shelter is currently full, as most shelters are right now. And as well, we've got our 6 supportive housing units. Those are also full. We've got 5 units with folks in them and 1 that's in the process of turnover. Residents are following programming from their support at ACNL. So I've got someone from my caseload in the apartments. There's also some folks who get other kinds of support from other staff at ACNL, but they're just supportive housing units where folks are able to, have some on-site support. And again, like similar to the shelter, the priority is folks living with one of those infections, but at risk kind of includes most community who's looking for that kind of housing. So that's a little bit about us and what we do. We're now going to move into a poll. So I'm just curious to know how much people know about HIV and hepatitis C before we kind of get into it. So we've got a poll coming up. How much do you know about HIV and hepatitis C? We've got 3 options: significant knowledge. You feel like you've got a pretty good grasp. You know quite a bit about HIV and hepatitis C, and you're just sort of interested in what the process of getting folks connected to our services look like. Maybe you've got, second option, some knowledge, a little bit about these infections, but you want to get a bit more of a knowledge base. And then no knowledge, you might just not know a lot. And that's no judgment at all. Like, that's why we're all here, is to learn, right? So just to see what folks are thinking. So I think, yeah, we've got a good balance here. So I'll push this out so that you folks can see kind of who's around. So Most folks said some knowledge, some folks said no knowledge, and no one really feels like they have a significant amount of knowledge. So yeah, we're open to meet people who have some knowledge or no knowledge, kind of boost that knowledge up and figure out how we can best support people who might be living with these infections. Oh, that's awesome. We're going to move now to talk about HIV. So the way that we're structuring, I'm going to talk a little bit about HIV, and then I'm going to pivot and start talking a little bit about hepatitis C. So as always, if I'm going through, if there's anything you have any questions about, feel free to pop that in the Q&A, and at the end, we'll go through the questions and try and make sure everything's been addressed. All right, so to start off with, what is HIV? So HIV, or human immunodeficiency virus, is a virus that weakens a person's immune system. The virus uses CD4 immune cells, also known as helper T cells, a type of white blood cell, to replicate, destroying them in the process. So basically, there's a white blood cell, the HIV kind of attaches, uses the white blood cell to replicate, and then kind of bursts out, destroying the white blood cell. So when a person's CD4 cell count is low, they're less able to fight infections. Today, HIV is more treatable than ever, and many people with HIV live long and healthy lives. So it is no longer, the traditional stigma about HIV of it being really grave and serious. It is something that people need to live with, but we typically kind of tell folks that it's similar to managing diabetes or high blood pressure. It's a chronic health condition. We can manage it, with medication. And so what is AIDS? Because folks, sometimes get mixed up between HIV, AIDS, aren't sure what the difference is. So AIDS is the acquired immunodeficiency syndrome. It's a syndrome caused by the HIV virus. A person is diagnosed with AIDS, or we often now call it advanced HIV, when your CD4 cell count is below 200 cells per millimeter cubed of blood. So not super relevant, that number, but it's when the white blood cell count has dipped below a certain level that leaves a person's immune system very compromised and leaves them vulnerable to serious infections, which we call opportunistic infections and cancers. Thanks to effective treatment, most people with HIV in Canada never do progress to advanced HIV or AIDS, but that really depends, and especially is exacerbated by inequalities like unequal healthcare access, if folks are unhoused and unable to take their medication consistently or like store their medication. So it's important that for folks in vulnerable populations, we're trying to provide as much wraparound support as possible to make sure that their infection doesn't progress. So that's sort of two ends of the spectrum, but there are stages of an HIV infection, three main stages. So there's the acute infection, the chronic infection, and then an advanced infection or AIDS. So the acute infection develops 2 to 4 weeks after exposure. It's usually accompanied by flu-like symptoms, so things like fever, diarrhea, swollen lymph nodes, night sweats, but often it can be completely asymptomatic. So it's hard for folks to know whether or not they have an HIV infection. During this time, there's a really high risk of transmission because the HIV is replicating pretty quickly and building up in the blood. So folks are more likely to pass it on. After that point, after about the 4 week, stage, we move into a chronic infection. So that's when HIV is replicating in the body without causing a lot of outward symptoms. It's still absolutely affecting the body and depleting those white blood cells, but it may not be as noticeable to folks. And that can last up to 10 years without treatment. So it's really important that if folks feel like they might have been exposed to HIV, they should get tested. And then after that point, once those white blood cells have been depleted, we move into advanced HIV or AIDS with that low CD4 cell count and the really high risk of opportunistic infections. We want to make sure that folks aren't getting to that point, so we're trying to get folks to get tested, use preventative measures, and we want to be able to catch it early. So in terms of preventative measures, we should talk a little bit about how HIV is transmitted. So there's this sort of equation that looks at how HIV is transmitted. So it would be a fluid plus a route plus an activity. So a fluid that contains HIV plus a route into the body plus an activity that brings those two pieces together is a risk of HIV transmission. So there are 5 fluids that pass HIV, and we'll kind of get into each of these segments, like the fluid, the route, and the activity. We'll kind of break it down. So, like I said, there's 5 fluids that contain enough HIV to transmit the virus. They are blood, semen, so cum, including pre-cum, rectal fluid, vaginal fluid, and breast milk. So these are the 5 fluids that contain enough HIV to transmit the virus. It's important to note that saliva is not on here, mucus is not on here. It's just these 5 fluids. So the likelihood that one of these fluids will contain enough HIV to pass the virus is determined by a person's viral load. So a viral load is a measurement of how much HIV is in a person's blood, and that also affects concentrations in the other bodily fluids as well, and it's measured in copies per milliliter. So while these are the 5 fluids that can transmit HIV, the likelihood of one of them actually passing the virus along really depends on how much virus is in a person's blood, what their viral load is at. But these are those 5 fluids. So for one of these fluids to pass HIV, they need to find a route into the body. And there are 2 major kinds of routes that one of those fluids can take to get into the body in order to transmit HIV. So one is the mucous membranes, or sort of the wet linings of the body. So the vagina, the rectum, up sort of underneath the foreskin, between like the head of the penis and the outside, like in the foreskin, and as well the opening of the penis as well. Anywhere that there's like one of those wet linings, that's a place that those fluids can transmit HIV, which is why unprotected sex is one of the ways that HIV is most commonly passed. As well, broken skin, so injection or piercing into the body. Usually what that looks like for HIV transmission is sharing injection drug use materials like syringes. And yeah, so if someone who has HIV has injected their drugs and they share that needle with someone who does not have HIV, it's possible that that's a way for HIV to pass from one person to the other. So as I said, activities bring one of those fluids containing HIV together with those routes into the body and make that risk of HIV transmission. So unprotected anal and vaginal sex would bring rectal fluid, vaginal fluid, cum, pre-cum, all of those wet linings, all those fluids. There's a possibility of HIV transmission. Same thing, like I mentioned, with sharing injection drug use supplies. And as well, breast or chest feeding typically isn't recommended for parents who do have an HIV diagnosis because breast milk can transmit HIV. Now, we're looking at ways for, there are some parents where breastfeeding or chest feeding is very important to them. So there are ways that they are able to do that with the guidance of a doctor, with strict adherence to treatment, because we don't want to take away folks' agency and their ability to, parent the way they would like to. But typically, we recommend formula feeding. It's also noted here at the bottom that HIV can be transmitted through the placenta during pregnancy. That's called vertical transmission. But here in Newfoundland, HIV is a typical part. An HIV screening is a typical part of prenatal screening, just because we want to make sure that if someone is pregnant, we're able to catch any HIV infections sooner rather than later. And once a pregnant person is on safe and effective treatment, the risk of them passing HIV on to their baby significantly decreases. So, in talking a little bit about HIV and how it's transmitted, it's a little important to also talk about how HIV is not transmitted. So casual contact like hugging or kissing, shaking hands, that's not going to pass HIV. Same thing with coughs or sneezes. Like I said, saliva, mucus, not really anything that's going to pass HIV, not a concern. Same thing with toilet seats, water fountains, public swimming pools, sharing those kinds of devices and things. HIV doesn't live very long outside the body. And as well, like I said, unless there's one of those 5 bodily fluids that is able to find a route into your body, that's not going to pass HIV. So we're going to do a little quiz. This isn't really, for the chat or anything. This is kind of for yourself. So you can mark down your answers and check them in the next slide. So we're looking at, could this transmit HIV? So A, heterosexual sex, assuming two cisgender heterosexual people, penis and vagina without a condom. B is sharing equipment to inhale drugs, so like a crack pipe. C would be oral sex without a barrier, so or condom or dental dam, so giving or receiving oral sex. And D would be sharing injection drug supplies. So I'll give folks just a second to kind of scroll down their answers on their piece of paper before we move to the next slide. Okay, everyone have their answers locked in. We're going to move on. So here are our answers. So A, heterosexual sex without a condom can transmit HIV. Like I mentioned, that fluid, vaginal fluid or semen into a root, so tip of the penis, foreskin, vagina. That activity can bring those fluids and those roots together, so that could pass HIV. In terms of sharing equipment to inhale drugs, that's typically not going to pass HIV. And that's one prevention method that we recommend for folks, is finding other ways to use drugs other than injection. I will note that sharing equipment to inhale drugs can pass hepatitis C, which we'll talk about in a little bit. But in terms of HIV, that's not going to pass it. Oral sex without a barrier, also not going to pass HIV. No way for those fluids to get into a root. And that's also, again, a prevention method that we recommend for HIV, is finding other ways to engage in sexual activity that are still going to, bring you closer to your partner, initiate pleasure, but are going to keep you from passing HIV or other STIs. Like I said, similar to in crack pipes and Hep C, oral sex without a barrier can pass other STIs like herpes, chlamydia, gonorrhea, that kind of thing. But in terms of HIV, not going to pass it. And then, like I mentioned before, sharing injection drug use supplies is going to pass HIV. Not definitely, but it is a possibility. So one thing for folks in the social work field, depending on where you are and where you're practicing, one thing that may be good to keep in mind is universal precautions. So we don't all set out to have a day where we interact with blood and bodily fluids, but we know it's possible for that to come up. So the first piece here, this is adapted from the Canadian HIV/AIDS Information Center, is to treat all blood and bodily fluids as infectious. That's kind of got a twofold reason. One is to keep yourself, your colleagues, your clients safe. If we treat all blood and bodily fluids as infectious, then we can make sure that we're cleaning them all up appropriately. And the other piece is to try not to stigmatize folks, right? We don't want it to seem like we think certain folks are more likely to carry disease than others. We want to treat everybody equally and try to avoid creating any stigma around these kinds of sexually transmitted and bloodborne infections. Another piece is to cover cuts and open sores with a plastic bandage. That just keeps all of those, openings into the body covered and keeps you from possibly transmitting something. Wearing gloves, if you might touch bodily fluids, is also great. Again, keeping, cuts, sores, openings into your body closed. And as well, washing your hands with hot water for 20 seconds after contact with bodily fluids. Discarding garbage properly in biohazard bags or sharps containers is great. And swap housed sharps containers if that's something that you're looking for or you need in your workplace. And as well, if bodily fluids do come up, a 1:9 ratio of bleach and water should clean everything and make sure that there are no viruses around. So Another form of HIV prevention is sort of adapting activity. This is part of what we do in harm reduction here at ACNL is, we know folks want to engage in sexual activity. We know they want to engage in substance use, and we just want to create ways that they're able to do that as safely as possible and trying to avoid transmission of HIV or other sexually transmitted and bloodborne infections. So when it comes to sexual activity, we recommend folks use condoms and lube. Lube in particular is often less emphasized than condoms. The barrier of condoms is fantastic. In keeping those fluids away from those routes into the body. But the other thing is that lube makes sure that there's not a lot of friction in sexual activity. And when there's a lot of friction, there can often be openings of cuts, sores, tears, that kind of thing that can increase the presence of blood in sexual activity and actually make it more likely for HIV or other sexually transmitted and bloodborne infections to pass. So condoms and lube as a pair are fantastic. As I mentioned as well, engaging in alternate sex acts, so oral sex, mutual masturbation, things that still allow folks to be close with their partners, but don't necessarily bring that fluid and that root together are great. And as well, getting tested for STIs regularly is something that we recommend, usually every 3 months for folks who are sexually active. But again, if folks want to get tested more frequently, if they've had an exposure, that's great. And we say STIs, not just HIV, because other STIs like syphilis, gonorrhea, having those can actually weaken kind of the immune system, or they can have, sores in the genital area that can make it easier for folks to catch HIV. So getting tested for those STIs regularly, make sure that if there is anything that needs to be caught, we can get treating it as soon as possible, and as well making sure that there's nothing that can increase the likelihood of contracting HIV. Pivoting to substance use, using new drug use supplies each time a person uses drugs is sort of the gold standard of what we want. We want folks to be using their own supplies so that there's no risk of bodily fluids passing from other supplies. As well, if folks do need to be sharing supplies, we do recommend using drugs in ways other than injecting, like snorting, smoking, swallowing. That's going to prevent the transmission of HIV through sharing injection drug supplies. There are also 2 medications. My slide headings are a little strange here, I apologize, but there are 2 medications that can prevent HIV. So there's pre-exposure prophylaxis, or PrEP, and post-exposure prophylaxis, or PEP. So pre-exposure prophylaxis is taken before a potential HIV exposure to avoid transmission. PrEP is not just a pill or a medication, it's actually a regimen. So that includes regular blood work and STI testing. Part of that is because if someone is on PrEP and they contract HIV, we don't want them to develop sort of an immunity to that medication, because PrEP is an antiretroviral that can also treat HIV. So we're just trying to make sure that we're screening folks and making sure they're not in a position where they might be developing kind of an immunity to that drug. PrEP is usually prescribed by a family doctor, but it can also be prescribed by folks in collaborative clinics. It really depends. I know a lot of folks don't have a family doctor. The sexual health clinic in St. John's does prescribe PrEP, as well as, I believe, Planned Parenthood, but I know that is not always an option for folks outside of the St. John's area. If folks are looking for help finding a PrEP prescriber, they're welcome to give us an email, and we can reach out to our networks in their area and see if there is anyone who does prescribe PrEP. It's covered under NLPDP with a special authorization. So there is some criteria that needs to be met for it to be covered under NLPDP. And that special authorization is on our website if folks want to look through. It's typically for gay and bisexual men who have sex with men, folks with a partner who has HIV, but like I said, all of that is on the special authorization, and if necessary, we can assist in advocating for folks who want PrEP. The other side of that is post-exposure prophylaxis, or PEP. That's taken after a potential HIV exposure to avoid transmission. It has to be taken within 72 hours. That's 3 days of HIV exposure. It is a 28-day course of medication. Often folks will go to emergency, get 5 pills in hand, and then have to get the rest of their prescription later. It can be quite expensive, but it is sometimes covered in full by infectious diseases. So it depends on where folks are going. Sometimes the hospital doesn't know how that coverage mechanism works. So again, if folks outside of St. John's are looking for PEP, I would recommend they go to the emergency room, understanding that there's a potential for that cost. But if they get that 5-day course and then need assistance with the coverage for the rest of the other 23 days, I encourage them to get in contact with us. And same thing if that's a client that you have and it's outside of St. John's, we can work with some of our partners to try and make sure that that gets covered. One other way of preventing HIV is something called U equals U, or treatment as prevention. So that means undetectable equals untransmittable. So a person who is on effective HIV treatment and maintains an undetectable viral load under 50 copies per milliliter cannot transmit HIV to their sexual partners. This is somewhat new. It's a little bit newer for folks. People might not be as familiar with it, but it's a great advancement in HIV care. It's helped a lot of folks. So like I said, if someone is undetectable on an HIV test, they can't transmit it to their sexual partners, and there's a very low likelihood that they can transmit it through sharing injection drug use supplies. I do want to make a note on U equals U. It's important to note that some people with HIV are unable to reach an undetectable viral load due to factors such as their healthcare access, other health conditions, housing instability, systemic inequalities. But even if a person cannot reach an undetectable level, treatment is still great. It still reduces risk of transmission, improves a person's overall health, and any lowering of that viral load is great because we're keeping HIV out of that person's body to wreak less havoc on the body. So U equals U is fantastic. And even if folks can't reach undetectable, HIV treatment is still wonderful. So like I mentioned, we talked a little bit about prevention. This is a little bit about treatment. But before someone can get on treatment, they have to get tested. So we'll talk a little bit about HIV testing now. So HIV testing in St. John's and everywhere is pretty much the same. There's a blood test that folks can do, and as well an HIV self-test. But one of the most important pieces here is the window period. So it's the time between someone's been exposed to HIV and when an HIV test can detect HIV in someone's blood, also known, as we've been talking about, as their viral load. So, this can range from 2 weeks to 3 months, depending on the kind of HIV test. But it is important that the only way to know if you have HIV is to get tested. So 2 different window periods, but should always be getting tested if folks are concerned about an HIV diagnosis. So the time between the exposure and the window being closed for a blood test, 2 to 6.5 weeks. So getting tested less than 2 weeks after your exposure can leave folks vulnerable to not having time for the HIV to build up in the body and to get that result. So usually we want folks to wait until about 6.5 weeks to get that blood test in a lab. Now, if someone does want to test in the window period, they absolutely can, but typically we want them to test again at the end of the window period just to make sure enough time has passed for HIV to build up in the blood, if it is there, for the person to get an accurate result. So a blood test is a typical way to test for HIV. We also have HIV self-tests. These, take about 3 to 12 weeks in the window period. They're a great option for folks who are less comfortable in the healthcare system, but that window period is quite long, so people might not want to wait a full 3 months to get tested. It truly depends. Someone might come back after, 4 months after an exposure and realize they might need to get tested. And so a self-test is a great option at that point, but it's really up to the person. The other thing about a self-test is that it's not confirmatory, so a person will have to go back and get a lab test if they test positive. But we'll talk a little bit more about self-tests in a little bit. Like I mentioned, we're mostly St. John's based, so HIV testing in St. John's. We are very fortunate that we're one of the only places in the province that has sort of dedicated sexual health clinics, like the NLHS Sexual Health Clinic, like Planned Parenthood, like the Harm Reduction Clinic. So for folks located in St. John's, these are all great options. Some of them are appointment only, and you can call them to book. The Harm Reduction Clinic is walk-in, and they also do community outreach, so they're a really great low barrier option for folks. As I said, you can give them a call as well for more info. Outside of St. John's, things look a little bit different. I can't list every single person who might be able to do testing outside of St. John's, but usually it falls into 3 buckets. So folks have a family doctor. I know that those can be kind of few and far between now, but family doctors can do up requisitions because, like I said, HIV is tested for through a blood draw. So it is just getting a requisition to go, get your blood drawn. As well, public health nurses often are able to do STI screening as well. And we've also had some success with folks outside of St. John's with virtual care. So folks going on Medicuro, Maple, those kinds of services, getting that blood work requisition, and then being able to go out usually to their hospital and get that drawn. I know that it can be a concern for folks in smaller communities with the kind of confidentiality, kind of everybody knows everybody. But that's kind of where we are right now in terms of testing. So if anyone has any other questions about how we can facilitate testing for folks in other communities, please feel free to shoot me a message. One option for folks, like I said, is HIV self-tests. So these aren't confirmatory, but they are really helpful for folks. They provide results within minutes. They only require 1 drop of blood, and they're 99% accurate at detecting HIV. So we can ship these across the province. Like I said, swapped as mail out, so I can mail these out to folks. Other organizations have them as well, like the Safe Harbor Outreach Project here in St. John's, like Planned Parenthood. And they might be a great first step if someone's a little bit hesitant to go into a medical setting to get that test. And also, if folks are in St. John's, they're welcome to come into the office and test with me. So I'm going to show you now a video of what that HIV self-testing looks like. There is a small drop of blood, I will let you know, for folks who might be a little bit squeamish. This is a POS person, positive meaning he has HIV. His name is Travis. You might recognize him from the pit crew, Canada's Drag Race. And he did a video with CBRC to kind of show you what it looks like to test for HIV.
Canada. How does it work? Let's find out. First thing you're going to want to do, open this baby up, then get out all of your materials. Keep that Band-Aid close. Line up your bottles. This one's a little harder to get out your little tray. Then you're going to want to open this up, and at first you might think, gosh, that's a lot of words. Give yourself a breather. The main ones you need to care about are these. Take a minute. You're going to feel like you want to drink. Don't do that. Read through this carefully so you can follow the directions as closely as possible. What I like to do, pro tip, is open the Band-Aid first because you only have 2 hands so you don't struggle through it. And it's ready. Open the bottle. Get it ready for your blood. Here we go, time to do the finger prick. Take this off first. Make sure you get a good fleshy chunk. Side of the finger is optimal. And just press. And then milk it from the base until you get a good little droplet. There we go. Now it's time to put on your Band-Aid. Close the lid of step 1 firmly. Shake it 4 times. You really want to see this red color in the bottle before you pour it into the tray. Pour the liquid into the tray, nice and slowly, and wait for it to absorb. All right, now, bottle 2. Pour the liquid into the tray. Yep, we lost a little. It's okay if you lose a little, just keep going with the test. Wait for the liquid to absorb again. And grab bottle number 3. Pour the liquid in carefully if you can. And again, wait for the liquid to absorb. I think I know what I'm gonna get. As you can see, 2 dots. She's positive, HIV positive. The top dot might look a little faint, but as long as it's visible, the test is valid. And if you have 1 dot, you're HIV negative. So pedestrian.
All right, so yeah, that is what those tests look like. Super simple to use. We do them in the office with folks often, but they're also an option if people would like to test by themselves at home in a place where they feel safe, in an agency they feel safe, with people they feel safe with, so it's an option for folks. And like I said, if it does come up positive, like Travis's result, they would have to get confirmatory testing, but often people are just testing negative and it's a little bit for their own peace of mind. So like I said, those can ship across the province. Our supply is a little bit limited, but we are able to ship them if folks are interested. So if someone does test positive for HIV through a self-test kit and then they go through the blood test and that's also positive, a few things will happen. So the first is contact notification. So HIV is a reportable disease. That means that when someone tests positive for HIV, the healthcare provider completing the testing must notify public health that there's a new confirmed case of HIV. Public health will then reach out to the sexual and needle sharing contacts of the person with HIV to notify them of a potential exposure and provide testing information. It's really important that if you are working with someone who's getting tested for HIV, that they're aware of this and that their consent for testing is informed. It's never going to be helpful to tell folks that, it's completely confidential. Folks need to know that if they are getting tested for HIV, it's possible that public health might reach out to them, that their result might be given to public health, and that, their contacts might be shared, not identifiably, but that, folks in their life might be contacted if they do test positive. So like I said, if public health reaches out to the sexual and needle sharing contacts of someone who has tested positive for HIV, that's usually a collaborative process done with public health and the person who's tested positive. So they'll be providing the information for the people that are going to be contacted, and the nature of the exposure won't be revealed. So nobody will be called up and say, hey, somebody that you had sex with tested positive for HIV, or hey, somebody that you were using drugs with tested positive for HIV. It's usually just, hey, we have reason to believe that it's a good idea for you to get tested for HIV. Public health will do that with any sexual or needle sharing contacts shared by the person who's tested positive from the last 6 months prior to a positive test. So it's something that folks do need to know is a possibility when they do get tested. Another thing that happens when somebody tests positive is that they're connected with the HIV clinic. So it's also known as the immunodeficiency clinic. It's located in St. Clair's Hospital in St. John's. So no matter where the person is located, they will be connected with this clinic. The team is led by Dr. Jatine Morker. They also have a lovely nurse practitioner, pharmacist, social worker. So it's an interdisciplinary team, and they work together to support the person living with HIV. They can help them determine the stage, like we talked about, of their infection. find the right HIV treatment for them. There's a few different medications. They can find the one that works best for that person, get them started on the treatment. And as well, their social worker is really great at getting coverage for that HIV treatment. You can either be covered through NLPDP. There's also patient support programs. So those are programs done by the pharmaceutical company to get that coverage. So typically, folks shouldn't be having to pay a significant amount for their HIV treatment. Usually for folks who live out of town, outside of St. John's, they'll connect with people by phone. They want to see people in person at least once a year. So usually an initial appointment will be done in person, and then they'll do follow-ups in person about once a year. So when it comes to HIV treatment, as some may know, there's no cure for HIV. Like I said, it's a chronic health condition, but it's managed through treatment taken consistently, and people living with HIV can live long and healthy lives on treatment. So HIV is treated with a kind of drug called antiretrovirals. You might hear it called ART, antiretroviral therapy, or ARVs, antiretrovirals. These are all the same thing. It's a type of drug. Typically, a person will take several drugs packaged into one pill. There are a lot of different kinds of antiretrovirals, but we don't have to get into all the different kinds. Basically, people usually take one pill with a couple different drugs in it, and it's important for them to take it every single day. So adherence is what we call it. It's a really important part of HIV treatment. So like I said, not everyone's going to hit undetectable, but there's lots of benefits to beginning and adhering to HIV treatment, which includes improved overall health and decreased risk of cancers and infections. If someone does reach undetectable, there's no risk of transmitting HIV via sex. Healthy pregnancies and HIV-negative babies, as I mentioned, when it comes to vertical transmission. And as well, if someone reaches undetectable, there's definitely a decreased risk of transmitting HIV through shared drug use supplies. Ideally, we want everybody to be using their own supplies every time, but we want to also decrease the risk because, people are sometimes in positions where they're not able to do that. Like I said, adherence is taking HIV treatment exactly as advised by a healthcare provider. So time of day, frequency, with or without food. We know for folks who might be marginalized or vulnerable that might be difficult. So if we're working with folks who do struggle with their HIV treatment adherence, there are some strategies we can help with. Things like creating a daily routine around HIV medication. So something that we've done with folks is, pairing it with their methadone if they're getting that. That's a daily medication as well. Or pairing it with their first cigarette of the day, something like that helps people. If they've already got a routine, just incorporate it into the routine. If folks have a phone or an alarm clock, being able to set an alarm to take that medication can be great, or even a note on a calendar when their treatment's taken, kind of ticking off the days so they know that they've taken it for that day. As well, those weekly pill boxes are super helpful for folks as well, because there's kind of like a visual reminder that they've taken the medication for the day, similar to the calendar. So that's a little bit about treatment and what treatment adherence looks like. We're going to pivot now to talk a little bit about HIV and the law. So as we get into this, important to note, I'm assuming all of you, am not a lawyer. I am a social worker. So this is not legal advice. It's just a little bit of information. And I'm hoping it is something that we can take forward into practice to make sure that we're supporting people living with HIV, appropriately, and making sure that we are feeling comfortable in our ethics as we move forward. So HIV in Canada is criminalized, meaning that people with HIV can be prosecuted if they don't disclose their status to their sexual partners when there's a duty to disclose. No other infection is criminalized like this, even other sexually transmitted infections like herpes, which is transmitted similarly and is not curable. So this is a real specific singling out of HIV. The criminalization of HIV can cause quite a lot of harm to folks. It undermines public health efforts. People are much less likely to get tested, come forward if they're afraid of some sort of legal repercussions. it also kind of contradicts the message that everyone's responsible for their own sexual health, and it can cause quite a lot of harm to folks living with HIV, which is not a criminal condition to have an infection. Nope. When it comes to a duty to disclose, legally, a person with HIV has a duty to disclose their status when there is a realistic possibility of transmission. That's the quote from legal precedent. There's no one definition of a realistic possibility of transmission. What we know is that there's no duty to disclose when folks are engaging in kissing or other casual contact, or engaging in anal or vaginal sex when the person has a low, suppressed, or undetectable viral load and uses a condom. So there's a little bit of friction between the legal understanding of realistic possibility of transmission and the scientific understanding, because as we know, if someone is undetectable, has an undetectable viral load, they just physically can't pass the HIV on to somebody else, even if they don't use a condom. But under the law, it has to be a low, suppressed, or undetectable viral load and a condom. A person can be charged with aggravated sexual assault and placed on the sex offender registry for HIV non-disclosure. This applies even if they did not intend to cause their partner harm or to transmit the virus. Again, so if someone is undetectable, knows they can't pass HIV through sex, and doesn't disclose, if they're not wearing a condom, they can be charged. Even if their partner did not get HIV from them, even if they did not know or think they had a legal duty to disclose, or if they face challenges reaching a suppressed or undetectable viral load. So, like most other kinds of criminalization in Canada, HIV criminalization disproportionately affects Black people, Indigenous women, and gay and bisexual and other men who have sex with men. So there's quite a lot of stigma around HIV, and that causes a lot of harms legally and criminally to folks who may be disproportionately affected by HIV. So it's important when we're thinking about HIV disclosure and in our practice, any worries we have around HIV, to remember that there is a possible harm of criminalization for our clients living with HIV. For folks who have clients living with HIV and would like for them to know a little bit more about their rights and their responsibilities of disclosure, in the additional resources bit, I've added a Know Your Rights pamphlet that's been updated in 2024. That's from the HIV Legal Network, and that lets folks know what their rights are, who they need to disclose to, who they don't, that kind of thing. So if we're worried about, somebody with HIV not disclosing their status to their sexual partners, under Canadian law, there's no specific duty to warn, the same way that there might be for some other conditions. There may be permission under the law to breach confidentiality to prevent harm to another person if the following 3 criteria are met. So if there's risk of harm to an identifiable person or group, so say you know that your client who has HIV has a partner, that's one person you can identify, and you're worried for their safety because you don't think that the person that you're treating is disclosing their status. If there's a risk of serious bodily harm or death, that includes HIV infection, and the danger is imminent. So this can't be, just a thought that you might have or a possible risk. There has to be something that shows that this is imminent. In that case, it is possible to breach someone's confidentiality. That's not typically something that we would recommend. We would recommend talking to the person, making sure that they understand their responsibilities. But if there is a situation where it feels like you might need to breach confidentiality, it's extremely important to note that breaching confidentiality does not mean disclosing somebody's HIV status. That's a piece of private health information that should not be made public. There's a different way of going about that. So if you're worried that you might need to breach confidentiality, there are a couple considerations to make. Like I said, don't make any assumptions. Talk to your client, see what they know about HIV disclosure. Like I said, I have that Know Your Rights pamphlet. It's actually quite a long booklet. If you are able to go through that with the person, make sure they understand their legal responsibilities, make sure they understand HIV prevention, make sure that there's a good understanding there. And if you don't have the understanding to be able to have that conversation, please feel free to direct that person to me, and I can have that conversation with them. As well, considering the harms, right? Breaching a client's confidentiality can cause harm to them and to your therapeutic relationship. So if you're concerned that someone, still knows all of their legal responsibilities and is still going to engage in actions that might put another person at risk, I do urge you to consider that breaching a client's confidentiality can cause harm to them criminally. Like I said, that's a really criminalized infection. No other infection is like that, so there's possible harm under the criminal system as well. Even if we're only telling the person who might be at risk that they might need to get tested, word travels fast in communities, and so it is possible that that person's private health information might be made public, even if that's not your intention. And as well, you need to consider the therapeutic relationship. Another thing here is to be open with the client. If you want to tell them their concerns, the process you're considering following, telling them, hey, I'm worried about your partner. I might reach out to someone that I know works with your partner and let them know that they need to be tested for HIV. Of course, there are situations where that might not work. That might be put the other person at risk, but it's always important to be as open as possible, especially if a client has trusted you with this kind of information. And like I said, lastly, disclosure or breaching that confidentiality does not have to mean disclosing the individual status. You should not be calling anybody and saying this person is HIV positive unless it's the clinic or someone that they've given you permission to share that with. A person's HIV status is their private medical information, shouldn't be shared. Like I said, it usually will look like calling somebody that works with the person who's at risk and letting them know about the possibility that they might need to be tested. So that's just a little bit of a breakdown of HIV and the law and breaching that confidentiality. Like I said, the number one thing is to not make any assumptions and make sure that your client has a clear understanding of what is expected of them under the law. As well, consulting with managers around policies and things like that will be really key. As well as the Know Your Rights booklet I've shared from the HIV Legal Network, I also shared a decision-making tree about breaching confidentiality to prevent harm for service providers, and that's also something that I recommend folks check out. This is a situation that I don't think comes up very much, but it is something that folks have asked me about and are concerned about. So like I said, generally speaking, we don't want to breach confidentiality. We don't want to share anybody's status. We understand the harms under the law, but it is something that could come up. And if it does come up, we want you to feel prepared. So that's the end of our section on HIV. I'll give you a second now if there's anything I didn't address in the section about HIV to type your questions in the Q&A just so that we can address them later. If there's anything you are curious about, feel free to pop it in the Q&A, and after we go through Hep C, which is shorter than HIV, I know we're at about 60 minutes now, but once we go through Hep C, we'll do a last little look at those questions. All right, so we'll jump now in the interest of time to hepatitis C, but like I said, if there are any questions that come up while we're going through, feel free to pop them in the Q&A. So we're going to switch gears a little bit and talk a little bit about hepatitis C. So what is hepatitis C? Hepatitis C, or HCV, or Hep C, is an infection of the liver caused by the hepatitis C virus. HCV damages your liver over time and causes scarring that can lead to liver cancer and liver failure, also known as cirrhosis. So unlike other forms of hepatitis, there's no vaccine for Hep C. There's a vaccine for hepatitis A and hepatitis B, but Hep C is curable for 95% of people with one simple treatment. Like HIV, hepatitis C has stages of the infection. So there's an acute infection and a chronic infection. So the acute infection is the first 6 months of an Hep C infection. Sometimes it takes me a minute to switch over. 1 in 4 people clear the infection spontaneously or without treatment during this time. That's the number we're given, but typically we want to start people on treatment as soon as they test positive, just to make sure. A chronic infection is the Hep C infection after 6 months, and it requires treatment to be cured. So that can cause damage, like I said, to the liver, but also to the pancreas, kidneys, heart. So it's important for folks to get started on treatment as soon as possible. Hepatitis C is transmitted blood to blood. So where HIV has 5 fluids, hepatitis C has 1, and it's blood. So it is passed when blood that contains Hep C enters the body through a break in the skin, like injection, or through the linings of the nose and the mouth. Hep C can also live outside the body for days, different than HIV, which doesn't live outside the body for very long at all. And in environments like a syringe where it's closed and damp, it can live for weeks. So Hep C can also be transmitted via blood too small to see. So dried blood that's really small can pass hepatitis C, which is why it's important for folks to be using new drug use equipment every time, and to not be sharing things like personal care items. So, like I said, these activities will typically transmit hepatitis C because they'll go blood to blood. So sharing supplies to use drugs, that includes smoking, snorting, and injecting. If someone's sharing a crack pipe, for example, there's usually that can often cause like cracks in your lips and stuff. And so if there's a little bit of blood on the pipe that you can't see, you pass it to the next person. Either they have cracked lips or the lining of their mouth, that can pass hepatitis C. Same thing with snorting. If you've got, a straw that you're sharing, you get a little blood on it and you pass it to the next person who puts it into the lining of their nose, that can pass hepatitis C, but it's most commonly passed through sharing, injecting drug material. Reusing piercing, tattoo, or medical equipment. The reuse of medical equipment is not very common in Canada, but in terms of piercing and tattoo equipment, for those who are incarcerated, that's a really big driver of hepatitis C transmission. Folks don't always have, sterile needles to give each other tattoos, so that can sometimes pass hepatitis C for folks who are incarcerated. Sharing personal care items, like I said, things that might have blood on them, like razors, fingernail clippers, tweezers, that kind of thing. Little bits of blood you can't see can pass Hep C. And again, certain kinds of sex, so like condomless anal sex, sex where blood might be present, that can sometimes pass things blood to blood. In terms of hepatitis C prevention, as with HIV, we're looking at using new equipment every time somebody uses drugs, whether that be their cooker, their pipe, their straw, their needle, as well, not sharing personal care items. And like I said, condoms and lubes during sex, that lube to reduce that friction, reduce the possibility of introducing blood is going to be super important. As well, visiting reputable businesses for tattoos and piercings. We can't control what folks are going to be doing while they're incarcerated, and so we want to make sure they're doing things as safely as possible. But if folks are on the outside, try and use a tattoo or a piercing shop where everything is nice and sterile. I just have the universal precautions here again. Again, very relevant. Treating all bodily fluids as infectious, covering up any roots into the body, discarding garbage properly, and cleaning things up. All going to be important in making sure there's no blood. Like I said, they can live outside the body for quite a while and can be too small to see. So making sure that anytime that there might be bodily fluids or blood around, that we're cleaning it up properly is just great for workplace safety. Like I said, hepatitis C is pretty common among folks who have been incarcerated. About 25% of people who have been incarcerated in Canada have been exposed to hepatitis C, and that's a rate 40 times higher than the general public. So I want to make extremely clear that this is not something specifically to do with people who have been incarcerated. It's not that those are populations who are, less likely to use protection. It's just that in that kind of space, people are less likely to be able to access safer supplies like safer substance use supplies, condoms and lube, sterile tattoo and piercing supplies. So it's just that it kind of spreads through prison because people are not able to access the things that they need to keep themselves safe. So it's important that if you have clients on your caseload with a history of incarceration, it's a good idea that they get tested for hepatitis C. Right now, I know at HMP, a lot of folks are getting tested and treated, but when they're released into community, it can be hard to keep track of folks and make sure that they're still connected to their treatment. We're working on kind of creating a plan for folks once they've been released. But if you do have somebody on your caseload who's been released from incarceration, it might not be their primary priority, but a hepatitis C test would be a great way to make sure that they're taking care of their overall health. Hepatitis C testing is done with 2 different kinds of blood tests. So there's a screening test and a confirmatory test. The screening test looks for hepatitis C antibodies. So if antibodies are detected, it means that the person has had hepatitis C. It doesn't really determine if the infection is active. It just means that the stuff is in somebody's blood to fight hepatitis C infection. If someone's already had hepatitis C and we're testing for reinfection, they usually skip that screening test because that person will always have the antibodies because they've had hepatitis C before. When it comes to the confirmatory test, that looks for hepatitis C RNA, which is the genetic material of hepatitis C, which means that the virus is replicating and the infection is active. So typically that will be something that they do the second time after a screening test. There's also genotyping that's done with hepatitis C to figure out kind of what specific genotype someone has and figure out what treatment they need. But typically, these are the main 2 tests just for confirmation of an infection. Like I said, St. John's has these sexual health clinics like the NL Health Services Clinic, the Planned Parenthood Clinic, and the Harm Reduction Clinic. In other parts of the province, you'd be looking at things like family doctors, public health nurses, online clinics if possible. I know some of the ODT hubs are also testing for hepatitis C. Like I said, though, I don't have a full list for across the province, but if you are looking for help finding Hep C testing in your area, please feel free to let me know. As well, an important note is that in November, so prior to November, there was a requirement for folks to get a Hep C test, wait 6 months for another RNA test to make sure that it is actually replicated or replicating, and it's not going to cure itself, and then start treatment. But in November, that requirement was removed. So folks no longer have to wait that 6 months for their infection to possibly clear by itself. So yeah, once somebody tests positive now, they're able to start treatment right away. And if there is somebody that you have on your caseload who's looking to start treatment, feel free to send them my way as well, and I can help connect them with the prescriber in their area. So like I said, if someone does want to start treatment for hepatitis C, it's pretty simple. 95% of people are cured of hepatitis C with 1 course of treatment. And that doesn't mean that the other 5% just continue to have hepatitis C. It's usually that they'll just require a second course of treatment, or they might have something a little bit more complex going with their liver. But usually Hep C is extremely easy to cure. Hepatitis C is treated with drugs called direct-acting antivirals, or DAAs. They cure Hep C in 1 course of 8 or 12 weeks with minimal side effects. Folks might be familiar with the old way of treating hepatitis C, which was interferon-based and had a lot of side effects that would make people feel really bad. But the current class of drugs, the direct-acting antivirals, are very mild on people. Sometimes they need a little bit of time to adjust, but it's really not that difficult for most folks. Getting cured of hepatitis C does not protect people from a reinfection, so they can be cured and then reinfected, but they can also be cured again. So that's a little bit about what Hep C treatment looks like. Like I said, these are kind of the treaters that we work with. Dr. Peter Daly is fantastic. He is working out of St. John's, but we also chat with him to see who he knows in different parts of the province, and we can connect people with prescribers across the province. And like I said, the Harm Reduction Clinic in St. John's is fantastic. And there's also a centralized referral process at HMP run by Dr. Jennifer Leonard. Patients may be told that Hep C treatment will only be covered by NLPDP once, but we can assist in advocacy for reinfection treatment coverage. there's no way for us to end hepatitis C if we're only treating people once and they get reinfected. So we're trying to make sure that folks are able to get treatment whenever they need it. Similar to HIV, Hep C needs to be taken every day in the same way that doctors prescribe it to be effective. It's 8 or 12-week courses, so 2 to 3 months. That can be a long time for people to consistently take a medication, especially if their lives are a little bit less stable than they would like them to be. So some strategies, like I said, that may help is creating that daily routine. The OAT, the methadone and HCV medication together has been a really effective combo for many people. So that's definitely an option. As well, getting the medication in blister packs, similar to those little pill organizers. They're really helpful to see whether or not you've taken that pill for the day. And also then you don't have to fill up the whole pill thing every time. So really depends on the person, but there's a lot of work that can be done to try and help make that a little bit easier for folks in a really low barrier way. One of the last pieces here is around hepatitis C treatment and drug use. So same thing with HIV, but people do not need to be sober or drug-free to get treatment for hepatitis C. That is not a requirement, and sometimes folks think it is, so it's really important that we are clear to them that sobriety is not a requirement for Hep C treatment. Most Hep C medications don't have dangerous interactions with street drugs, but Hep C medications can change a person's experience of a drug, even one that they've used for a very long time and are very familiar with, and might increase risk of overdose. So it's important if folks are starting Hep C treatment that they really keep an eye out for that, starting low, going slow, and carrying naloxone. We want to make sure that people are able to be treated for Hep C, but we also want to make sure that they're being safe in their substance use and that they understand that treatment might change their experience of certain drugs, and making sure that they're carrying naloxone and using with people they feel safe with. So that clues it up for me on Hep C treatment and HIV. So I'll leave it open for some questions if folks are interested.
Hi, Julia. Thank you so much for this excellent presentation and material. We don't have a lot of questions coming in, so I guess people are still trying to, absorb the information. But we did have one particular question around who orders for HIV the take-home kits, the take-home testing kits. Who would order those? So if you had a client who was looking for that, could the social worker order that test, or does the client have to specifically ask for that test to be mailed to them?
Yeah, I mean, social workers can definitely order a test from us if they're interested in getting one for a client. We can also ship directly to the client if that's something that they would prefer, but we do ship across the province, so it doesn't really matter. We don't keep a lot of track of who's ordering what. We just want to make sure we're getting stuff out to folks.
Perfect, great to know. Another question we have is around if you do have a client, and certainly you spoke about the wonderful work of the AIDS Committee of Newfoundland and Labrador, for individuals individual social workers who might be working with clients, any tips in terms of how best to support clients who are living with HIV or hepatitis C?
Yeah, I think it's really important, for folks to, if they feel comfortable, make sure that they're really holding space for folks' experiences, especially with HIV, which is a huge paradigm shift in terms of how you're living your life. It can be a really big new diagnosis for folks. So I do a lot of supportive counseling. So of course there's the tangible support of, if you're able to, if your mandate allows, taking people to appointments and helping them manage their medication, that kind of thing, but also just giving folks a little bit of grace to kind of adapt to something new, and that there's often still a lot of stigma around.
Okay, excellent, thank you. Someone else is just wondering in terms of demographics, and are there particular age demographic that you're seeing mostly in terms of who are in receipt of services from the ACNL?
It really depends. Yeah, it really depends. It kind of cuts across age demographics. We certainly have some folks on our on my caseload who have been with the agency for years and years and are kind of long-term survivors. They're a bit older, but we also are seeing folks with newer diagnoses who are a bit younger, maybe in their 30s, and who are navigating a new diagnosis. So it really depends.
Okay, thank you. Just in terms of other questions that people might have, keep them coming in. We do have a little bit more time. So thank you for those. And I guess years ago, Julia, I know the ACNL was working on a project around HIV infection pertaining to seniors. Is that still work that the ACNL is doing around that particular demographic population?
Yeah, so that we did do a project. It's called, I think, Sex Over 50, and that has some information about, HIV in particular, but also sex for seniors, all kind of sexually transmitted and bloodborne infections. I think we're rolling some of that out in some long-term care facilities. We might be partnering. I can't be 100% sure if I'm honest. But there's definitely some information about that I have. And if folks are interested, I can definitely send it out to them.
Excellent. Thank you. We have another question. Someone notes that you talked about drug use and Hep C treatment. Wondering about those taking Suboxone and the Hep C treatment.
Yeah, so I know for a lot of folks, pairing the OAT, so the opioid agonist treatment, with Hep C treatment is really effective because they're both daily medications. I don't believe that there's any sort of pharmaceutical interaction between Suboxone and Hep C treatment, but that is something that prescribers and pharmacists will have a little bit more insight in. But I know in like some ODT hubs and that kind of thing, the Suboxone and Hep C treatment will be really helpful.
Okay. Wonderful. Thank you so much. Another question that we've had, still some questions coming in. In terms of, I know you talked about this in the presentation around the saliva and transmission of Hep C or HIV through saliva. Can you give a little more insight, information around that?
Yeah, for sure. So there's often one of the biggest questions I get day to day is, can XYZ pass HIV, casual contact or oral sex or something that involves saliva. And so I think it's really important that folks are like aware that it's just the 5 fluids, like I said, so blood, semen, rectal fluid, vaginal fluid, and breast milk. But it is something that comes up quite a lot. So that's kind of the core that we can always go back to is, does it involve one of those 5 fluids?
Right. Yeah. Excellent. Thank you. Excuse me. Another question that just came in is around age for treatment. So someone's wondering, is there an age restriction on hepatitis C treatment? For example, can young children receive treatment?
That is a great question. I typically don't work with children, so I don't have an answer, I think, for you. I can't imagine that it would be like restricted for treatment. We don't want anyone to have Hep C when it is curable, so I can't imagine that we wouldn't be able to treat children. But again, not a doctor, so not quite sure what that would look like.
Okay, no, fair enough. Perfect. Thank you. Another question that's come in is around stigma. Are you still seeing through your work that there's still a stigma pertaining to HIV or hepatitis C?
Yeah, I think we're in a really particular moment in time, which is a bit difficult, where medication has really advanced for HIV and Hep C, and folks are able to live pretty normal lives with those infections. And particularly with HIV, what that unfortunately means is that people often aren't very open about it and aren't in community with other people with those infections. So it can feel very isolating for people and kind of drive that stigma because there's less openness about it. So that's something that we're kind of seeing. We did start up an HIV support group that we're trying to get running so that people do have that community, but the stigma is still very much present.
Okay, Thank you. And just scanning through the chat box there and the questions, I'm not seeing any additional questions come in. So you would have covered all the information in your presentation, Julia. So thank you. It was quite comprehensive. So I don't know if you had any final concluding remarks that you wanted to make before we, adjourn from the webinar, and I'll make a few concluding remarks as well. But is there anything else that you kind of wanted to highlight or wrap up from the questions or from the presentation this morning?
Oh, yes, I will. I went to the question slide, but I did want to show we've got sort of some further learning that's going to be in the resources, but I also have a workshop evaluation survey with a QR code up here if folks have a few minutes to kind of scan that QR code and just let us know how you found the presentation, if there's anything that you would have wanted to see different. And I guess to conclude, thank you all so much for coming and for being interested in this presentation. This is something that we're trying to make sure that there's a lot of awareness around, and so I really appreciate your time today.
Wonderful. And I just want to thank you, Julia, for facilitating this excellent webinar for us today in celebration of Social Work Month, and for sharing your knowledge, expertise, and experience. And I think for those who are, engaged in the session this morning, that regardless of your area of practice, and I think Julia, you said this at the beginning, the information that you shared is so important in terms of our own professional knowledge, and to the people that we might be working with who are living with or impacted by HIV or hepatitis C and other sexually transmitted bloodborne infections. So, just wanted to say, we hope this webinar sparked your interest in learning more. And I do want to thank Julia for taking time from your busy schedule to facilitate this very informative session for us today. It is truly appreciated and a wonderful webinar to kick off Social Work Month. So RSWs attending can claim 1.5 CPE credits for attending this webinar as per the NLCSW CPE policy. The PDF of the presentation, so the slides, are also available in the resource section on the webinar platform, along with those other great resources that Julia talked about. And we also have an evaluation form. So if you want to complete that, it will appear on your screen. Your feedback is always appreciated. And we'll also share that with Julia as well. But you can choose where you want to complete that evaluation for sure. And just a note to say thank you to everyone for joining today. And we hope that you enjoy the rest of your day and all of the Social Work Month activities that you may have planned within your organizations. So thank you, everyone, and happy Social Work Month.